Hi, everyone. Good afternoon. My name is Clara Odakura, and this is my informational interview. So, the why behind the interview, I had the opportunity to interview a good friend and current colleague of mine, who's actually a physical therapist, but someone I really admire. Besides from being a wonderful human, she's a very strong therapist. She's innovative, creative, and very holistic, and very articulate with her thoughts and visions and descriptions of therapy. I knew that she had a rich history in pediatrics. She started out in the NICU, which has always been a field that I have been very interested in, but never really explored since just some simple fieldwork experiences during my didactic part of my OT program. So I really wanted to learn just more about her experience of being a therapist in the NICU. So what I learned was that therapy in the NICU is very complex and requires a lot of training and knowledge. She mentioned that you have to know all of your lines. You also have to be very aware of the infant's medical history and day-to-day changes. She mentioned that it is helpful to be available for rounds when the neonatologist and other members of the team are going around because it is truly a setting that changes constantly. So it is good to be in communication with your fellow medical colleagues. In addition to having that medical background, you also have to be very conscious of infant signs of distress. So, my colleague talked about the autonomic signs of stress that you look for in an infant, such as drops in saturation levels and O2, physical signs of distress, such as tremors from the baby, or the baby may be turning or looking away. She mentioned you have to be aware of their breathing patterns, if there are changes in their rib cage, look if their arms are flailing out or even closing their eyes. That might be a sign that they are overwhelmed and overstimulated. So really the number one priority of therapy in the NICU is making the baby feel calm and safe. So additionally, building on top of that medical knowledge, you really also have to have a strong understanding of development. Um, so my colleague talked about how therapy in the NICU may vary drastically depending on if your baby is a 24-weeker versus a 30-week-old infant. For those that are more medically fragile, you may just be working on containment or positioning or hands to midline, where more of the later term babies, you may be working on things such as feeding or swallowing or range of motion. Additionally, on top of the direct patient care that you're providing, a large portion of being a NICU therapist is education to other medical professionals, but also to parents of this baby. So the person I interviewed talked about you have to be very conscious of your communication and who you're talking to. These are overwhelmed parents. You have to take in their occupational, their history, their profile. Do they have other children? Was this a first birth? How are they feeling about holding their child? Are they scared? Are they aware of the importance of skin to skin contact? What are their obligations outside of the hospital? So you have to take into account communication and who you are speaking to. While I really truly enjoyed this opportunity um, and to interview my colleague, what I found really fascinating was that she was able to be a part of the culture shift in the NICU. So at the time when she was a therapist in the NICU about a decade ago, they were undergoing this transformative shift from where they were going to really family-centered care. So looking at the baby and what the baby needed versus the medical needs. Obviously, if it was an emergent medical need, that had to be dealt with first. But if it was not, their goal and emphasis was to really be aware of where the baby was at in development, and to create this change in culture where they looked at really reducing the amount of sensory input in the environment for the baby. So she mentioned things like noiseless trash cans and cluster care. They also created the expectation that there would be quiet hours. So the lights would automatically dim. And this is a time where not the therapists, nurses, or doctors could touch the baby. They had to respect that this was quiet time and a time for the baby, to really try to emulate that calm environment of where they're supposed to be, which is still in utero. So, what was confirmed during this interview? My colleague mentioned time and time again the skill of communication and building rapport. So, this is a position where you are working alongside a host of different medical professionals, respiratory therapists, speech therapists, PTs, OTs, neonatologists, nurses, especially. She mentioned that over and over again, that you really have to build a strong rapport with your medical team, as well as being aware of your communication with your parents and, of course, the babies. So, when I asked my colleague what the hardest part of being a therapist in the NICU was, I had kind of expected her to say, obviously, um, it holds room for a lot of sadness. There's a lot of sickness and anxiety and trauma in these people's lives. But while she did mention that, she really said that the hardest part of her job was really dealing with other medical professionals, in particular, professionals who had been there in the hospital for a long time that were not as welcoming about the culture shift to really focusing on that developmental care versus focusing just on the baby's medical needs. So, a few things that I did not ask, but later wished that I did, was asking her about, did she miss this job? How did they, once a baby was discharged from the NICU, what did the continuity of care look like? As well as, since I'm interested in going into this field one day, what are traits that or she believes to be essential for the makings to be a good NICU therapist?